is a picture of Dr. Takaisu, who initially described this condition in Japan in an annual ophthalmological meeting, and it was initially diagnosed in the retinal artery vessels, which showed both constriction and aneurysms. And coming on to epidemiology, it's more common in the Asian population, uncommon in Caucasians, and there is a gender predilection with women more afflicted than men. And there's slight geographical variation with respect to Takaisu in terms that thoracoabdominal aorta is more commonly involved in Indian population, whereas the initial descriptions in Japan were mostly of the neck vessels and ascending aorta. It mostly affects women in the second and third decade of life, though the gender difference is much less pronounced in children. And the three stages through which the arthritis proceeds is the first is the early systemic or pre-vasculitic stage where there are constitutional symptoms. The second is the vascular inflammatory phase, and then the burnt out or fibrotic stage. This is the stage in which we pick up most of the patients, and it's already probably very late in stopping the further progression of the disease. So pathologically, there is inflammation of the vasa vasorum of the media and adventitia with mononuclear cell infiltrates and giant cell granulomas. There could be aneurysm formation, there could be stenosis as well as thrombosis because of the inflammatory milieu in this particular disease. The diagnosis is often missed in the initial subacute phase and usually picked up because it's very non-specific in the early phases of inflammation. Constitutional symptoms like weight loss and fever are very common. 1/4 of patients with TAC do have tenderness over the carotid arteries, gangrene, claudication, syncope, and Raynaud's syndrome are other forms of presentation of Takaisu. The often misleading symptoms which make us think of the other DDs rather than this are palpitations, SOB, and chest pain, which makes us think of other causes of LV dysfunction or coronary issues. And shortness of breath is due to reduced ejection fraction, AR and root dilatation and hypertension. The less common presentation would be myocarditis or coronary ostial narrowing and GI symptoms. About 1/2 of patients have PA involvement, though not clinically very apparent. Coming to whether childhood TAC is any different, not really. The only thing is that it has more severe manifestations, and in any case of renovascular hypertension, do think of Takaisu, and it has to be proactively ruled out. Coming on to what criteria hold good for children, the EULAR or Printo criteria is applicable to children, and it mandates the typical angiographic abnormality of the aorta or its main branches, plus one of the following, which again is very similar to the adult criteria, which has pulse deficit, BP discrepancy, bruit, hypertension, and elevated acute phase reactance. And this is something we are all familiar with, type 1, 2A, 2B, 3, and 4. As I mentioned, I would like to again emphasize that type 3 and type 4 are much more common in Indian population, and that's been something that we've seen in our patients as well. And coming on to what the most common presentation would be, it would be hypertension or heart failure in the majority of patients. The same was seen in our patients as well. Renal artery stenosis occurred in around 2/3 of patients that came to us with TAC. And we had a mortality rate of around 13% in acute admissions with TAC. So how do we go about investigating the imaging modality? Conventional angiogram is considered the gold standard, and it's often required before interventions and for taking a pullback gradient. But CT angiography is probably preferred in most centers as the initial investigation of choice and to give us a roadmap as to what to go for. And it gives a luminogram, vessel tapering, and very important vessel wall thickening, which may be an indication of acute inflammation. And coming on to MRI, it's very safe, radiation-free, and can be used as a repeat imaging modality, but the expense is a downside to it. Wall edema and thickness can indicate disease severity and activity as well. And coming on to FDG, PET, CT, or MRI, it detects active inflammation in new patients, and an FDG uptake indicates inflammation during relapses, and if on immunosuppression, needs a high cup of immunosuppression in such patients. And the most commonly available, probably in all centers, would be a Doppler ultrasound. Indeed, very useful, especially if the neck vessels are involved. Often not very useful when descending thoracic aorta, which cannot be properly imaged by ultrasound, is involved. And a wall thickness is a predictor of disease activity per se. So our experience, CT angiogram and conventional angiogram are more often resorted to. So we'll just run through some of our cases. The first, a 15-year-old girl who was followed up elsewhere as a case of idiopathic DCM and came to us for evaluation. And what we found was LV dysfunction and some aortic regurgitation. And this is exactly what we found in aorta, the red markers, diffuse thickening of the aortic vessel wall, and a shrunken kidney. The left one is shrunken. So this is what we found on 3D reconstruction, where we found that there was almost discontinuity of the thoracic descending abdominal aorta, and there's almost no renal artery visualized on the left side and an absent or a shrunken kidney. So she was in activity, and we started her on pulse steroids and mycophenolate mofetil. And a DTPA scan showed that the left kidney was non-functional. We planned for aortobiofemoral bypass and with a left nephrectomy and renal revascularization. The presence of left kidney might only accelerate the hypertension and make her less responsive to drug treatment. Second case, a 25-year-old lady with hypertensive emergency was stabilized, found to have severe LV dysfunction. And here is what we found. We initially did her renal angioplasties bilaterally, and we found that the aorta was shaggy, got a 30 gradient across the aortic pullback. And we went on to do a Tyshak 1030 balloon dilatation of the entire aorta. And this is exactly the mess we landed in. To re-emphasize over here that she was not in activity. Despite that, we ended in a dissection of the aorta. Their aortas are really rigid and very prone to events after balloon dilatation itself. So we had to cross from the axillary side via the aorta and then ended up with stenting the aorta to tamponade the dissection flap distally. This was the end result after the stenting. A third case scenario, 17-year-old girl with chest pain, and ECG showed LM pattern. She was very sick at admission, and this is what we found on echo. Increased echogenicity of the ascending aorta and aortic regurgitation. So we have the same confirmed on angiography, and look at the left main over there, extremely thinned out. Sent for surgery, was found to have friable aortic valve mass, inflamed ascending aorta, and we could not revive her. And this is a more common case scenario, a stable child referred as a case of coarctation of aorta. And then what we find over here is a middle aortic syndrome with very, very well collateralized distal aorta. And this is how we went ahead with stenting of the aorta. So intervention versus surgical. When do we go ahead and do a surgical or interventional revascularization? Short segment disease and not very fibrosed, go in for a angioplasty. Endovascular surgery is preferred in patients who have a long segment disease, heavily scarred arterial segments. And there are no guidelines as to what might be better over the other. It depends on site of disease, and for renal arteries especially, PTA works very well, and our experience has been very robust with balloon dilatation of the renal arteries. And we have similar papers which say that balloon dilatation is actually very good, and in fact, better over stent placement in these patients. And for CAD, again, PCI is less preferred, and a CABG is a preferred modality because of increased rate of acute stent thrombosis and ISR in these patients. So treatment in children, the considerations that we put into practice are discrete lesions. Balloon angioplasty is a good option. If long scarred aorta, then surgery. Operating a child and inserting a graft is again a kind of it's a dilemma because the child outgrows and need more surgeries. And for renal artery, we've always found that balloon PTA is better than stenting it. The lessons we've learned over the last few years of experience, there is no age-sex predilection. We've seen patients as young as 4 years of age. An active disease may need urgent intervention despite the markers being positive. And there is no the drug of choice. We've been using mycophenolate mofetil extensively along with methotrexate in most patients as a disease-modifying agent. Recurrences are common. Neither balloon alone or stenting is superior. We'll have to see what the clinical scenario is. And it's a very, very highly thrombogenic state. We have to be aggressive on anticoagulation as well when we are operating on a patient who is in activity. And it's a very rapidly progressive disease with severe intimal hyperplasia and thickening. So we'll have to keep them on a long-term follow-up. So we need a high index of suspicion, and DCM, rheumatic heart disease, and hypertension are the usual masquerades. In these patients, we need to actively look out for aortic wall thickening and suspect Takayasu. So our protocol generally is intervention during the heart failure admission with pulse methylprednisolone therapy, rule out TB, and when chronic, initiate on steroids along with another disease-modifying agent, either MTX or MMF, though we prefer MMF in our patients.
Okay. Last.
Thank you all for the patient listening.
Yeah.